I think it's a good idea to follow the whole way from diagnostics to therapy in a conference, and by this work in a multimodality way.
We have started to collaborate very close with bioengineering because, well, the mathematical model applied to medicine may help us to predict the future.
It's great just to learn more, but also the interaction with our colleagues.
If people come and just sit and listen, then they don't necessarily learn as much as if they ask their own burning questions.
In 1978, the first successful switch operation was made, and then we talk about the switch operation where you switch the great arteries, because the 20 years before you would switch the atria, which is totally different. So yes, 40 years ago it was the first time when this was successfully done by Professor Hitchcock and his team. And as we saw yesterday when we had this national day with parents and patients and partners from the region, we had this first patient here, we had Professor Hitchcock here, and we had a pretty emotional moment of this pioneer work he did. And yeah, it's a special moment.
Surgeons, interventionists, everybody has been really committed to improving the results based on the past experience. And obviously technology has got better and better. There is still considerable improvement on the horizon. Intensive care was, in comparison with now, was primitive. Now it's very streamlined and subspecialized. So all these areas, imaging has become fantastic. So the surgeons have much better idea of what they're dealing with well ahead of going into theatre and finding something.
"40 years ago, we were not diagnosing transposition before birth. So my area of work is making the diagnosis before birth and then planning appropriate management for the baby. And I would say that the prenatal diagnosis has really taken off in the last 10 years for transposition. We were doing it before that for other more complex forms of heart disease, but historically the detection rates for transposition have been poor, and that's because we're dependent on people doing the obstetric scans to look at certain views of the heart in order to detect a problem. And when we started off, we taught them how to look at the four-chamber view, and of course that will be normal in transposition, so that's why it was not picked up. But in the last 10-15 years, we've invested more time in training them to pick up or to look at the correct views in order to pick up this, and it is satisfying when we're starting to see more and more cases being detected before birth.
It looks like each modality is given as a different view. So like one of the points of the discussion today was like MRI is definitely missing the pressure measurements that you may indirectly get from echo and maybe directly from cath. So that's why, for example, they were discussing that on cardiac catheterization in some cases, they bring the patient to the cardiac catheterization room because the MRI gives some information that actually were not the same they found on the cardiac cath lab. So the idea is to put all this information together to make the clinician more aware of the situation and more able to decide the best clinical practice for that patient. I don't think it's difficult. I think that really each modality is adding us something. It's like a puzzle, and each modality is given as a piece of this puzzle. And if we put all together, we really have a broad view of the patient and how we can best treat him or her.
We're covering a small topic, like transposition of the great arteries, but we're covering it in much greater depth than you would in a wider, bigger meeting.
The interaction you have, the discussions we have, and if you like, the arguments we have, it just shows there's not always a right way to do things. There's more than one way of doing it, and actually it is important to listen to somebody else's point of view and reach a compromise in there somewhere.
The intention was to offer a longitudinal walk through one heart disease in a multidisciplinary setting, which is pretty unique.
This kind of meeting that put together experts in different fields help us really to broaden our mind. The future is definitely to, keep what we had until now and integrate with new modalities, probably more advanced, probably faster. That's definitely the goal. So the idea is that CT and MRI at some point can become as a daily routine practice, as an echo, in order to get really to broad over our view of the patient and of the disease, and to treat the patient the best way possible.
The technology, skills and everything has moved much faster than we would have predicted 40 years ago. And now there'll be more imaging development, there's more robotic skill development on the horizon. There's more, instead of learning as a junior trainee, instead of learning on patients with your senior supervising, there are more and more simulators being developed. And so what you hope is that people will become skillful before practicing on a patient. And obviously that would be a good thing. So those are the areas where developments will take place. There'll be some developments in equipment, machines that are used for interventions and surgery, but I think there'll be a bigger focus on acquiring skills on simulators.
So the bread and butter for making a prenatal diagnosis is ultrasound. So we are very dependent on the ultrasound images, but techniques have improved. We have other tools within that, so there's three-dimensional ultrasound. In our own unit now we also have fetal MRI scanning, which helps us. But I would say the vast majority of the information we get is from the ultrasound still, even though we have all these additional tools to help us.
Well, technologies in this field, so in MRI and CT, is developing very, very fast. Nowadays we have very fast CT scan. So they made CT scan with very high resolution, so you can see stenosis of the coronary arteries, as we have talked before, very precisely. And then at the same time, the scan, it takes 30 seconds, 1 minute at the most, to get a full 3D image of the heart. MRI is still longer, but there are new techniques that allows MRI to shorter the scan, and then new techniques that allows us to go deeply into pathophysiology of the disease. 4D flow is an example, is the measurements of flow in 3 directions over time that makes the 4 dimension. And this allows us to see how the flow moves into the great arteries and into the ventricles, and predict some of the possible possible disease.
Probably every 2, 3, 4, 5 years you even feel that there is a step ahead, because something done 5 times, 10 times seemed to work well. So in this small community you communicate that it works. And also for this purpose, this conference is important, because tomorrow we're going to go for case discussions. We come with 3, 4 cases which are not very easy to solve. We will have a high-end discussion about how would you deal with it, so the progress in the way how you treat, how you operate or do CAS on these patients is pretty fast, and I would say every 5 years or less there are things changing and improving.
I'm an engineer. It was very interesting for me.
There was quite some discussion, and that makes it very interesting.
It was a great learning day.
Great conference. So
nice topics and good presenters.
It's a very good opportunity to hear some different perspectives on different subjects.
Very interesting.
Very dynamic day.